Good evening, everyone, and welcome to the Systems of Our Culture, the medical system in Alamance County. Today, we have with us the amazing, the wonderful, the talented Dr. Stephanie Baker. I'm not going to do her introduction just yet because we have somebody designated to do that. So, my name is Sharia Burnett, and I will be assisting in moderating this event. Our other moderator is Tony Riddle Autry. And now I will turn it over to Adrienne Barr to introduce our speaker.
Hello, everyone, and first and foremost, thank you, Dr. Baker, for being here tonight. So let's learn a little bit about Dr. Baker. So Stephanie Baker was recently promoted to Associate Professor of Public Health Studies with tenure at Elon University. She is a scholar activist, and her work uses a racial equity and anti-racism lens, combined with community-based participatory research approaches to understand and address racial health inequities. Her recent work, in collaboration with community partners, has focused on maternal and child health outcomes for Black women and communities of color, racial inequities in cancer care, and community academic partnership development and capacity building to address health inequities. She is an organizer and trainer with the Racial Equity Institute and is currently the academic co-lead for the African American Black Community Response Team, addressing the impact of COVID-19 on communities of color. Dr. Baker is also the co-founder of a new research lab called the Her Lab, and that's Health, Equity, and Racism Lab. She loves good music, delicious food, and spending time with her daughter. Please join me in welcoming Dr. Baker.
Thank you so much, Adrienne. And speaking of my daughter, she is in the background. So just a disclaimer, if we hear a little peep, that is who that is. So Sharia invited me tonight to talk a little bit about, racism in the medical care system. And you'll see some overlap between medical care and public health as well. So I'm going to talk for a few minutes and then, about 30 minutes. And then hopefully folks will have questions. I just, the caveat is that we could talk about this, for months. And so this is just going to be kind of an overview of some of the ways that I've come to understand a little bit more about this topic. So I am going to share some slides here as we move into the presentation. All righty, so the systems of our culture, medical care. So first, I'd just like to share a little bit about my path into this work. I actually started as a physical therapist in terms of my profession, and we learned nothing about racism or health disparities or differences in health outcomes at all when I was in physical therapy school. And so as I started to work, I started to see patterns and outcomes from my patients, patterns and access to opportunities to get better. And they were often based on a patient's race, ethnicity, as well as their socioeconomic status. And I really didn't know what to do with that. It was very frustrating being at the tail end of healthcare and not quite sure what I could do to help improve the opportunities for people of color. And so as I was, venting to my mentors, they said, I think you're talking more about public health. And so I've started to learn more about public health and realized I was very interested in public health because public health gets us a little bit closer to the root causes of differences in outcomes. But I also learned, even when I started engaging in my public health career, that we can talk a lot about, how your neighborhood and how your work setting and how education and things of that nature impact outcomes, and we can talk about those things all day and never actually bring up race or racism. And so, as I started to meet more people and connect with more folks around my frustration, I realized there are communities, there are people out there who are doing this work. And so I was able to thankfully connect with some of them. And that is kind of the path that led me to investigate these topics a little bit more deeply. So when I finished graduate school, one of my mentors, Dr. Jeannie Ng, she's pictured here on the far right, she invited me to be a member of the Greensboro Health Disparities Collaborative, which is a community academic medical partnership in Greensboro, North Carolina. It was founded by community organizers. And she told me that in order to be a member, I had to go to a 2-day training on race and racism. And I was really confused about why an Asian woman was telling a Black woman that I need to spend 2 days learning about racism. But what, there are certain mentors who I just follow their advice and don't ask too many questions about it. So I went, and it really transformed my life in many different ways. One way was that it helped me to understand that while I had certainly the experiences of racism, and I was, grew up in a family that really centered and valued learning about Black history. And, my mom went to Freedom School. Mom and dad were both the first class of a large group of Black students that entered the University of Illinois at Urbana-Champaign. But I didn't have a real strong analysis of race and racism and the structural and cultural foundations of how it impacts every aspect of our society. So I'm forever grateful to Jeannie Ng for encouraging me to go to that training. The other two people you see pictured here are just other people that I have to give tribute to. In the middle, there's Dr. Bill Jenkins, one of my mentors. He passed away a couple of years ago. He has always been talking about the importance of understanding racism in public health, and has been an activist, from his days as a child on the Sea Islands in Charleston, South Carolina, to his days at Morehouse and working at the CDC as well. So he helps me be bold. Dr. Jenkins was one of the people who leaked the fact that the Tuskegee study was still going on when people thought it was over. He's been incredibly courageous and steadfast at making us realize that racism is a public health issue, as has Dr. Kamara Phyllis-Jones, who I encourage you all to follow and look at her articles. She has gifted us, some allegories and stories about understanding racism and other types of issues that can be difficult to understand. She's an epidemiologist, a physician, former president of the American Public Health Association. And part of the reason that I like to put these folks up on the screen is because, understanding racism as a medical care issue, racism as a system, racism as a public health issue, they weren't always able to talk about this so freely. And so I have to acknowledge the fact that there are people who've been doing this work way before I came, and that my ability to continue in this work is really, based upon their contributions and sometimes their silencing as well. So I'm just grateful for the folks who led the way for me. So medical care, why do we care about racism in the medical care system? Well, because we have outcomes from our medical care systems that demonstrate there are differences in health issues and diagnoses and experiences in the healthcare system based on race, ethnicity. So sometimes we hear them referred to as health disparities. Sometimes people refer to them as health inequities. And people tend to use these terms interchangeably, but I do think it's important to recognize that there are some inherent differences just in the words themselves, right? So a disparity, is acknowledging that there are differences between outcomes. So if we're thinking about something like birth weight, babies who are assigned male at birth tend to be heavier than babies who are assigned female at birth. And that is a difference. That's a disparity. That's a difference. On the other hand, there are also inequities, and these are things that occur because of differences in social conditions and exposures. They're due to inequities and unfair policies and practices and histories. And I appreciate the fact that that term inequity just really helps us to see that, first of all, it's unfair, and second of all, that there's something that can be done about it. So similar, to birth weight disparities between babies assigned male or female at birth, there are also differences in birth weight based on a baby's racial or ethnic identity. And so Black babies tend to be born smaller than white babies. That's an inequity. That's not due to some type of chromosomal difference. And so it's important to recognize and acknowledge those things. So as we're talking about racial disparities, one of the things that I've committed to doing whenever I can is having a conversation about what race is, that we talk about race and racism a lot in our society, and most of us aren't coming to the conversation with a shared definition of what we're talking about. And so race, Dr. Jones provides us this definition that it's the social interpretation of our physical appearance in a given place in time. And I think it's so important to recognize that your racial identity or the category that you are considered to be in can change over time. It can also change on where your physical location is. So who you are in the United States may be somebody, you might be totally different in Brazil, and you might be totally different in South Africa. So that shows you that it is a social construction and it is arbitrary, yet it has very real impacts. You know, your social interpretation of who you are impacts how our systems see you, how you're treated in our systems, and the types of access you have to resources and opportunities. Now, I put this Bill Clinton quote on here only because, during his administration was when the Human Genome Project discovered what many of us already knew, that there was no genetic basis for race. For our modern day categorizations of race, there was no genetic basis. And so he says that human genome is, in genetic terms, all human beings, regardless of race, are more than 99.9% the same. And so to know something is about 99.9% certain, and to still have people utilize genetics as an explanation for why we see racial differences in health outcomes is incredibly problematic. So I like to just be real clear that race is not genetic, that we all need to just understand that there's not something biologically inferior about communities of color compared to white people. And so that explanation for why we see differences in outcomes is just insufficient, it's inadequate, and it's inaccurate. And I really appreciated that, after, when we saw all these statements coming out after the murders of George Floyd and Ahmaud Arbery, Breonna Taylor, that, the Department of Human Genetics at the University of Chicago actually made a statement, and they acknowledged that, their field of genetics plays a part in creating this false social hierarchy that has led to many of the manifestations of race and racism that we see today. So again, we got to align ourselves around definitions of race, and we also need to be aligning ourselves around definitions of racism, because oftentimes when we're having these conversations, we're not talking about the same thing. Some people, when they're talking about racism, they're talking about the displaying of a Confederate flag or the N-word, for example, while other people are having conversations about structures and systems. And I'm really grateful for this series because we really do need to understand the systems reality of racism, because what we have come to understand, and when I say we, I'm just kind of talking about my collective community of organizers and educators and researchers, is that we could take all the people who identify as outwardly racist and send them away, but we would still have the same type of outcomes in our systems, because our systems are actually created in ways that allow those types of inequities and differences to be produced. So a lot of the analysis that I use is based on the Racial Equity Institute's groundwater approach. And so Sharia has the link to this report that you can access from the Racial Equity Institute's website. And just a brief description of this groundwater approach, we borrowed from Dr. Kamara Jones's use of allegories to create this story, to help us to understand a little bit more about race and racism. And so the idea is, we're talking about kind of the fish in the lake analogy, which many of you may have heard before. If one fish is belly up dead, then you might ask the question about what happened to that individual fish. But if you walk by, a lake and you see multiple fish belly up dead, that we have to change the question from what happened to the fish to what happened to the water. And so if we think about the fish as individuals and the lakes as our systems, our education system, our healthcare system, our banking and lending system, our transportation system, so on and so forth, that then, that question then needs to be what's going on with our systems that are creating so many horrible outcomes for so many people who are interacting with them. But when we're talking about racism, we have to ask the next question, and we have to ask ourselves, when we look across all of those systems, all of those lakes, we see similar inequities. We see the achievement gap in the education system, or the opportunity gap, more currently being referred to. We see health differences in our health system. We see banking and lending differences in our banking and lending systems. And so those patterns are the same across all the lakes, across all the systems. So what is filling up all of these lakes to have such toxic and typical and predictable outcomes, where it tends to be that communities of color have the worst outcomes, white people have the best outcomes? Well, what draws all of those systems together, all of our lakes, all of our water sources together, is the groundwater. Groundwater is not, 95% of the fresh water on our Earth's surface is in the groundwater. So if we can see racism as a groundwater issue, that it was built into the history and structure of our society to actually impact all of our systems in very similar ways, then perhaps we can start getting to the root and the actual diagnosis of what's happening and what's going on across our systems. So there are a couple of graphs in that report that I've put here. You can kind of take a look at them a little bit more in your own time when you have more time to process. But essentially, when people talk about systemic racism, this graph is showing outcomes for the United States, which show that no matter what system we're looking at, if you look at the poor outcomes from those systems, that Black people are more likely to have a negative institutional outcome. So we're talking about health tonight, and the two indicators from that system that we have on this graph are infant death, so babies dying before their first birthday, and death from diabetes as well. So even as we talk about medical care, though, I think it's important for us to acknowledge that we can't really talk about it in isolation of the other systems that are operating, right? So if you are experiencing an incarceration, aren't you probably also more likely to have a negative mental health issue and subsequently a negative physical health issue? If you, are below proficient in fourth grade and you experience unfair penalties, from behavior in the classroom, might that impact, how you interact with other types of systems? So we think that, we have to be thinking about all these things at the same time, even as that's a really difficult and challenging thing to do. The other thing that's important to note is a lot of times when we're reporting out information about health disparities, convention is to put the outcomes of the people who are doing the worst as kind of the comparison group, and to have the outcomes of people who are doing the best as the baseline. But one of the things that we do in the groundwater approach is we flip the script and say, well, what if Black people in this case, which is represented by the red line, are the baseline, and white people instead are the comparison group? Well, now we start to see something different, right? We're trying to figure out what's going on with Black people. Here we have to ask ourselves, well, what's going on with white people? How is it that white people have advantages across so many different systems? What's going on in that case? And so I just wanted to share that because I do think the groundwater approach is a very useful tool to start understanding and analyzing some of these issues from a deeper perspective. And so I encourage you to visit the Racial Equity Institute website to learn a little bit more about the offerings to go farther into depth there. But one of the conclusions, from that report is that we live in a racially structured society. And ultimately, that is what's causing racial inequities. So if we go back to this graph here, we could talk all day about why Black people are more likely to die from diabetes compared to white people, and a lot of times those answers will be the answers that people come up with will be around behaviors, or how, access to medication and things of that nature. But what we know is that while those things might matter to some degree, they don't explain the fullness of the racial inequities. And in fact, the reason that we have these racial inequities is because we live in a racially structured society, and our healthcare system was created and built during a time where Black people didn't have access to anything, right? During a time where Black people were captured and enslaved Africans, where the goal was to annihilate the American Indian communities, and during a time where there weren't many other racial and ethnic groups present in the United States context. So the buildings, the techniques, and all those types of things were created to advantage white people. Now, some of those techniques were created on the backs of Black people who did not have the right to consent, to participating in some of those types of research studies and things of that nature. But it was created in a society where we didn't have access to those things. If you're interested in learning a little bit more about that history, I encourage you to check out the 1619 Project, which has had quite a bit of publicity lately. But this episode, it's about bad blood is really great because it talks about, what did people do as a consequence of not having access to services? How did communities organize to address issues around illness and care? And, there was, for those of you who aren't familiar with the history, There was a period of time where Black people could not go into the same hospitals as white people, could not go into the same type of clinics. And oftentimes the hospitals that were serving people of color, communities of color, did not have adequate equipment, did not have adequate tools, did not have the correct type of surgical rooms that were needed for certain types of procedures. If you look into all of your communities, you'll learn some really interesting histories around that. So it's important to know that even in our present day, that we also still have low resource hospitals and really well-resourced hospitals. And oftentimes the poor resource hospitals are in communities of color. Communities of color have often created, different terms or phrases to describe these hospitals where it's like, if you go there, you're never gonna leave, that's where you go to die. So, people will drive past those spaces to try to get access to a better type of care experience. So 1619 gives a really nice historical perspective on all of that. So, bringing it a little bit closer to where we are now. During the Ronald Reagan administration, actually, the Secretary of Health and Human Services, who's Margaret Heckler, contributed to the production of something called the Malone-Heckler Report. And this was really the first time that our federal government had created documentation that there were racial differences in health outcomes. Now, that data had been being collected for forever. You can go back to W.E.B. Du Bois and the work that he created to demonstrate the inequities that existed. But this was the first time our federal government got behind it. And because of that report, Congress commissioned the Institute of Medicine to create this report. This is called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. Now, it's really important to know this report is publicly available. But if you ask your provider, have they ever seen it? I guarantee you they will say no. This report was a summary of across 100 other studies that had looked at outcomes. And this is for people who actually are interacting with our healthcare system. So this isn't about, access to care. This is when you do have access to care, you're still experiencing racial inequities in that experience. And so what you see here are some of the key findings. That, there's a significant variation in the rates of medical procedures by race. This is even when we consider insurance status, income, age, and severity of conditions, right? So race, and since we know it's not biological or genetic, racism is contributing to whether or not you have access to medical procedures, and not just random medical procedures. These are procedures that are considered to be appropriate care, standards of care. So, you ask a provider if they're biased, and most of them are going to tell you no, right? They're not biased. But what the data demonstrates is that they are biased, that just like, we like to get on police officers and people of different types of careers, but people in all of our systems are operating in biased ways. And those biased ways can have significant impacts on the communities that they're serving. What's really critically important to think about is that oftentimes when we're operating out of bias, our systems don't have any means of holding us accountable to those things. So we might not believe a patient is going to actually comply with a treatment recommendation or protocol. And so we don't prescribe them that protocol. And instead, we wait and watch, or we give them something that's less than ideal. Well, nobody has to account for that. That's just a decision that's made by your provider. And so then you end up with these health inequities, and people don't know where they come from because we don't measure them. We don't count them, and we don't hold people accountable for them, for producing them. So we know that providers do it. There's been plenty of data that demonstrate that our healthcare providers, and this is everybody from doctors to nurses to the front desk folks, absolutely have biases, and they make decisions based on their patient's race and ethnicity. Now, they may not be able to admit that because that's a difficult thing to admit when you're working on, in service of people. And you wake up believing that you are treating all your patients fairly, then that's just what you believe, but what the data demonstrate is that that's not happening. So now I'm going to show you just a few different examples of some of the current disparities or inequities that we are dealing with. So this is looking at new HIV diagnoses. by the US population by race ethnicity. So one of the reasons I like this graph is because if we had a truly equitable society, then we should see that all of our health outcomes should look representative of the percentages of people in the United States population, right? So if 60% of the United States is white, then 60% of new HIV diagnoses should be among white people. 12% the United States population is Black, well, 12% of new HIV diagnoses should be among Black people. But of course, we don't see that, right? We see that white people are far less likely to have a new HIV diagnosis. Black people are far more likely to have a new HIV diagnosis. Latino people also more likely to have a HIV diagnosis. Asian people less likely. And then we see these, these teeny tiny numbers for American Indian and Native Hawaiian communities. And this is a big issue in our data collecting that has gone on for decades, that continues to happen, is that we don't do a really good job of tracking folks in those communities. And this is a disservice to those communities because when you can't see what's happening, it's hard to prove or, show evidence that something needs to happen. So there has been, a lot of activism and movement in those spaces where you are seeing better data, but it's not well reflected in our, national data or the publicly available and accessible data that exists. The next set of slides are looking at pregnancy-related outcomes. So this is looking at deaths due to either childbirth or something related to pregnancy across the years. And the big take-home message here is the dark purple is Black women and the lighter purple is American Indian, Alaska Native women. And so it doesn't matter what year we're talking about, Black women and American Indian, Alaska Native women are bearing the brunt of dying from childbirth, complications from childbirth and from pregnancy as well. And, a lot of times people say, oh, well, this is just because of education, right? Like it's the issue around education, access to, good quality insurance, but no, that's not it. So they have looked at that. They've looked at the intersections of your education on your birth outcomes. And what we see here is the pregnancy-related mortality rate for Black women with at least a college degree was 5 times as high as white women with a similar level of education. What we also see is that the pregnancy-related mortality of dying because of childbirth or pregnancy-related complications for Black women who are college graduates or higher is actually worse than white women who have less than high school education. So just really, horrible data that's difficult to look at, but so critically important to know. A lot of people aren't aware of these inequities that exist. And so it's difficult to think about, what does this mean for you when you're pursuing pregnancy or somebody that you care about who's in these communities is wanting to have a child. We see similar rates with infant mortality. These are babies dying before their first birthday. So again, we see a little bit of reduction across the years, but overall, the highest infant mortality rates are happening among Black folks and also among Native Hawaiian and Pacific Islanders. I think that's an important community that is often understudied, often not discussed and talked about, but are certainly bearing the brunt of some of these inequities that we see. Breast cancer. This was one of the main outcomes that Greensboro Health Disparities Collaborative I mentioned earlier was focused on in some of their research. And so what you see here, these are incidence rates. So these are new cases of breast cancer. So white women are more likely to have a diagnosis of breast cancer, but Black women are far more likely to die from it within 5 years. So even when you have a case of an outcome that's, Black women aren't necessarily overly represented in, when it comes to the consequences of that disease, we see that inequity pop right back up. The other thing I wanted to just bring up is that, intersectionality is incredibly important. It's something that we don't always talk about, but when we're talking about racial inequities, for example, in violence, we see some interesting intersections between gender identity and race. So if we're just looking across gender identity, you know, we can see that trans women are far more likely to experience fatal violence compared to trans men, compared to other non-binary folks. But then if we look across the racial and ethnic differences and the way that it intersects with gender identity, we see that, you know, 75 out of 102 transgender people killed in the United States in the last 5 years were Black or African American. So, you know, we have to understand those nuances to really understand what's happening and what's going on. So, you know, a lot of times people want to get to solutions, right? Like you're telling us like this horrible stuff, like what are we supposed to do about it? And so solutions really do have to be multifaceted and multi-level. They have to involve a lot of different actors and a lot of different strategies. So I really like this figure because what it says is that, you know, we do have to acknowledge the history, right? The culture. And we also have to constantly interrogate, how is power showing up here? How is power implicated in how these systems and structures are operating? How is power implicated in how the medical care system is operated? Well, there's so many different power dynamics in terms of who's making decisions, who's accountable to who, the structure of healthcare systems, and who, you know, oftentimes you're accountable to your boss rather than actually being accountable to the patients that you're serving. And so we have to really think about how that lends itself to create these inequities and to perpetuate some of these differences in experiences that people are having. So in addition to addressing physician, you know, or a healthcare provider bias or privileges that people are experiencing, we have to also investigate the institutions and the structures, because that's what's holding it all together. And so the Greensboro Health Disparities Collaborative was really committed to doing that. Again, Mama Nettie Code was kind of the founder of the collaborative, and she knew someone who had a negative experience navigating cancer care, and really wanted to do something about it. And so this is a more recent picture. So Mama Nettie Code is not in this picture, but I think it's important to recognize that the impetus for this work came from somebody who was most impacted, a community organizer. It didn't come from the academy. It didn't come from a researcher. It came from the community. And this group of community folks came together and actually interviewed faculty to see, who do we trust enough, or who do we believe we can work with to do something about this. And so that's, you know, how Dr. Jeannie Ng got involved. She was selected because she had been doing a lot of community-based participatory research, which is an approach to research that really centers partnership and power sharing and assets, you know, acknowledging assets and really deepening and understanding what was going on. The other thing that the Greensboro Health Disparities Collaborative committed to was using a racial equity or anti-racism lens in their work. They said that we're not going to blame people for their experiences. We need to understand how our systems and structures are actually creating these inequities. So the founders of the Racial Equity Institute actually have their roots in the People's Institute for Survival and Beyond, which is a grassroots anti-racism organization that's in New Orleans. And they've been around, you know, for decades. They have some principles that are really important to think about as we're trying to shift issues. And we wanted to think about, well, how are these principles connected to the medical care system? And the two principles that the Greensboro Health Disparities Collaborative ended up focusing on in terms of, you know, solving some of these issues was transparency and accountability. And I'm going to talk about how we did that in just a few minutes here. So, you know, the collaborative and its work, and I sent that link to Sharia as well, because the greensborohealth.org website has all of our papers and all of our talks, and, you know, a lot of access to information to learn even more about the group. We have a couple of YouTube videos too that talk about our history and our founding, you know, how we function and how we act together. But what we realized is that there were ways that institutional racism was built into our healthcare system. And here are some examples of ways that we determined that was true. One, you know, protocols of care kind of being applied to all without consideration of race or ethnicity, and the assumption that this is actually happening and not actually tracking whether or not it's happening. The use of medical jargon and code words is a way to really disempower people who are using the medical care system. So, it's like, why does, if somebody's on their back, why do you have to say supine? Like, there's just, I don't even understand today, like, why we use those things. But what we do know is that it's a way to kind of build institutional racism into a system. Specializations in our healthcare system also is one example of how institutional racism is structured. So, when you have people who have multiple conditions and they're being seen by multiple different specialties, there's not a whole lot of conversation usually that's happening across those specialties. So you have these silos of care, and the patient is often responsible for bringing information or sharing information across providers, and there's not a whole lot of talk that's happening. So if you have a chronic pain issue and you have cancer, and you have, your general practitioner, it's like 3 different folks are treating you for 3 different things, but you're just one body, like you're just one person. So that's one way. And then also the fragmented power, right? So a lot of times people really feel disempowered to do anything, to make any changes. And this is a really important thing to think about, and maybe have a little humility for those healthcare providers who are interested in changing, because they don't get paid to go to, REI training. They get paid for care. They get paid to care for patients and to charge patients for the care that they're providing. So let me speed through the rest of this so that we actually have some time for questions. So we kind of separated the ways in which we see racial equity or inequities operating at the healthcare system into this transparency and this accountability category. So I kind of already talked about the transparency. So the goal was to avoid using that confusing jargon, providing consistent information, really thinking about personal communication modes. So, we found out in our study that when people get diagnosed with breast cancer, for example, white women are more likely to be called into the office. Black women are more likely to be told over the phone. And it's like, that's not okay. So we really need to be thinking about personal communication modes, being flexible towards patient needs, and then also having clear methods for assessing whether or not standards of care are actually met, tracking that information and then reporting it back to the providers. Who, might not really know what's happening, what's going on. And then also setting up measures of accountability. So having clear procedures for collecting and monitoring that data, being really clear about explaining processes of care and how people are making decisions, and then using real-time information that will tell you when a standard of care is being deviated from. It is, one of the things that we've done in healthcare that's been really problematic is we look at inequities after they've already occurred, right? Like this many people already died. We need to be tracking that information and when problems are occurring in real time so that issues can be addressed and checked. And so that's, that was a big part of this intervention. So I will, the good news is that through that structural level intervention, we were able to eliminate the racial disparities in breast and lung cancer treatment completion, and also improve treatment completion for everybody. And I think that's an important thing to consider as well, is that the way that we kind of talk about racial disparities in our society makes it seem like the goal is for Black people or people of color to have outcomes that are similar to white people. But what we say is that, the fact that we have racism in all of our system actually saps all of our systems from performing in their optimal way. So that, if we actually got rid of racism, then everybody's outcomes would actually improve, because you can't have a system that's having such poor outcomes for certain groups and that not impact other groups' experiences as well. So I'll stop sharing slides. I have stuff about COVID if people want to go there, but happy to take any questions.
Okay, we do have a few questions. I'm going to go through them. Hi, Stephanie.
Hi.
All right. So how does unequal treatment compare with the Monahan report of the 1960s that basically stated Black women were responsible for the decline in Black families?
Yeah, so that, that Moynihan report was really problematic in a lot of different ways. I wouldn't say that they're super comparable. I think what unequal treatment did was really call to account for how our healthcare system was producing inequities. So it wasn't a victim blaming situation. It wasn't blaming individuals. It was blaming our systems. And it was also putting out on Front Street that providers are doing this, and so I think that was a huge difference between those two types of reports.
How can we hold medical providers accountable?
That's a really, really great question that I don't have a really good answer for. I think, one of the aspects of the intervention that the collaborative did was we had a physician champion, and the physician champion was the one who received the reports about, what was happening in the system in real time, and they reported that back to their colleagues. So that was actually sufficient, to actually shift and change practice. Now, I don't know that it shifted and changed culture, completely, but it's really difficult to hold providers accountable. And I think that's something that we all need to really be thinking about a little bit more deeply. I think about my level of knowledge about everything, but when I went into labor with my daughter, it was like, just tell me what to do. It's like, this is the first time, that I had a baby. And even though I'd read books that said, okay, if her heart rate drops, you don't have to be on an IV. But I got on the IV, and so there was this power struggle, you're in labor. And so it was kind of this surreal experience for me, because I went in there thinking that I actually would have, advocated for myself in a stronger way. But I ended up just being really nervous, because the other piece of that is that Black women are dying, so it's like, and babies are dying. So it's a really difficult kind of thing. I would say that one way to start holding providers more accountable is for hospital systems to commit to looking at the data of what's happening in their own hospitals and starting to address those issues. I think that, doula support has been a really positive and has had a really positive impact on outcomes, because when you have another person there who can advocate for you and who can see, what's happening and support you, that's really critical. And doula support really needs to happen across whenever somebody's in the hospital, not even just for birthing, but for cancer care. Having that extra person actually seems to be a really useful way to start for providers to actually think a little bit more about what they're recommending.
What are some action steps that we can take to advocate for ourselves in medical settings? I know that you just talked about kind of like the nervousness.
Mm-hmm.
How did you kind of combat that?
Yeah, well, I think part of it is about, understanding that you do have agency in selecting your providers. One of the benefits, I guess you could say, of the type of healthcare system we have is that you don't have to stay with the provider that's treating you wrong. And we did, my sorority did a webinar, and one of the OBGYNs on there was like, if you feel in your gut something's wrong, don't question yourself. Like, go find you somebody else. There's somebody else out there that you will feel better about. Having more open and honest conversations, I think, with our friends and our loved ones about, like, who have you had care for you, that you felt listened to you, that you felt respected you. And then, trying to, and again, these are not solving the issue, right? These are kind of putting Band-Aids on it or doing what we can, while we also try to hold these systems and institutions more accountable. And I think it's important to recognize the both and of that, because if we only focus on like these kind of individual level strategies, we'll be doing those individual level strategies for forever. And, our grandchildren will be teaching them how to, have the best outcomes in the systems. So it really does need to be both and.
Do we see disparities in treatment or quality of care for those with Medicaid and Medicare? Is there any dehumanization of Black populations as how they're treated, like disparities and pain tolerance?
Absolutely. I mean, as a physical therapist, it's like when a patient came in with Medicaid, it just shifted the whole way that the front desk treated them. They had less quality care, less quantity of care. And it just wasn't right. I mean, I remember working at a senior citizen home, or like, I guess it was a long-term care facility, be a more appropriate term for it. But I had a patient who was dying from, end-stage kidney failure due to HIV. I mean, he was dying, but he had Medicare. Medicare pays for a certain amount of therapy. And so it's like, what am I supposed to, this man was in pain and was hallucinating. Then I had a patient who had Medicaid, 40 some years old, had a massive stroke, would have benefited from significant amount of therapy to produce, to help him get back. And they gave him like half an hour of therapy a day. Now it took about half an hour just to get him out of the bed, right? So you want me to spend an hour and a half with this patient who really should be experiencing a dignified death, because he's not coming back, and a half hour with this young man who actually has the potential for recovery. So insurance absolutely dictates care, and that's really frustrating, so it has an impact, and that's for it's across race and ethnicity, but we do know that people of color are disproportionately represented in those in like Medicaid and some of the other types of health insurance options. And some providers just don't take it. They don't have to take your insurance. So
is there anything similar to Greensboro Health Disparities Collaborative in Alamance County? Like, is there similar work being done in parts of Alamance County?
Yeah, so I think there probably is a lot that I'm not even aware of, but one group that I'm a part of is the Alamance Health Equity Collective. And that's a group of community and academic folks who come together to really make sure that our community health assessment has an equity focus, and that the improvement plan also is acknowledging the impact of race and racism on solutions. Now, if we want to get into like the logistics of all this, so the Greensboro Health Disparities Collaborative worked with Cone, who now owns Alamance Regional Medical Center. So I think we will start to see some of the shifts and changes that have happened in the cancer center there kind of blend over into Alamance County, but it's not happening super fast. I'm always kind of surprised, it's like when we find solutions, how long it can take for institutions to adapt them or to institutionalize them, or for them to even kind of spread outside of the particular space where they were created for. But I'm hopeful. I mean, I think we have a lot of people who are pushing organizations and institutions to do these things.
Hopefully they don't take their time like they did integrating schools.
Exactly. Exactly.
How did the collaborative create an understanding that racism does actually exist and move forward with solutions for change?
Yeah, so one of the, so everybody in the collaborative went to the People's Institute for Survival and Beyond at that point, to their Undoing Racism workshop, everybody. That was required for membership. And now the phase 1 Racial Equity Institute training is required for membership. I don't think people understand how valuable it is to have a shared analysis when you're addressing issues, because otherwise you'll spend all night arguing about, whose fault it was. But when you understand that it's the fault of systems and structures, and you hold each other accountable to keeping that at the center of your work, then you start to be more effective, in creating solutions. You could get real wrapped up in saying, when we're talking about cancer care, we could go into like, well, why don't we just have patients, be the ones who go into the rooms and say, I deserve this, I deserve that. And it's like, well, I mean, we could, But that's not the reason that the issue happened in the first place, right? So if we're going to really diagnose the problem from an in-depth and deep analysis, then the solution needs to follow what that diagnosis is. But a lot of times those solutions are hard. Now, don't get me wrong, you know, the collaborative has been around for 17 years, right? And the time it took to get to that inequity elimination was significant, and there were a lot of barriers that were experienced along the way. You know, first of all, when we have we have electronic health records, but our systems aren't set up to do the work that we needed to do, or to have the information that we need to have access to. And so the collaborative, was funded by the National Institutes of Health for this research project. They had to build the system. They had to work with computer folks, analysts, to build the system that they knew they needed in order to be able to indicate that, what was happening in real time. Now we're seeing some of that happen a little bit better in our present day. For example, when you look at COVID, I saw somebody had asked a question, like COVID, we're seeing it in real time because people have been organizing and saying, you must collect this data by race, ethnicity, and gender, right? Like in the beginning, they weren't even collecting that. And so we were all kind of being bamboozled about what was happening and what was to come. And so as soon as some of our House of Representative members start saying you have to collect the data and include race, ethnicity, then we start seeing the inequities pop up. We knew they would, but to be able to collect it like in real time has been a really interesting thing for me to experience, because again, most of the times we're looking at inequities after they've already happened. And so now we could say, okay, this many people have it, this many people have the vaccine, this many people are getting testing. So we need to shift, change, and, figure this out, because we still have some opportunities. Now, of course, far more people are dying than should have. But because they are collecting that data on a regular and consistent basis and reporting it, in real time or close to real time, that's been really impactful.
Is Alamance County addressing or responding to COVID in the Black communities in appropriate ways? And are there ways that community organizers can help with this?
Yeah, I mean, there's always more work to be done, and it's complicated for a few different reasons. One, I personally don't believe we should be forcing people to take vaccines, right? I think that we need to respect people's decision-making process and provide accurate information, because communities of color they are totally righteous to be concerned and to have questions, and those questions should be taken seriously. They should be answered thoroughly, and we should really kind of meet people where they are. And so so there's always more room. I was just looking at data that said, I think maybe 53% in the United or of North Carolinians in general, have been vaccinated. Those numbers, of course, vary by race, ethnicity, and they also vary based on the county. And so some other information that's been coming out, which I knew was going to come out, I was just waiting for it, was that there's this class disparity. So when you look at Black people who have been vaccinated, most of them are from middle class or upper middle class. Far fewer are from are living in poor circumstances. And so, there's still more to do. I think we need to really identify which communities have low vaccination rates. And if people don't want to get vaccines, then we need to be promoting prevention in every way possible, mask wearing, which is really the primary public health strategy that we can use right now. Yeah.
Is there a way for you to seek and search healthcare professionals that have been trained in racial disparities to provide healthcare that we can trust?
No, there's no, I have not seen it. Let me just say that people are creating all sorts of innovative things these days, and it is very possible something exists. I mean, my suggestion, I would, follow, certain providers on social media. I think many Black providers are becoming a little bit more forward facing or public facing. So kind of seeing, who they are, who's out there having these conversations. You can look up and see like what type of research providers are doing, to see like what topics are they addressing, how are they thinking about racial disparities. But it's a really difficult thing to do. My best friend is 44. She was diagnosed with breast cancer recently. And I was so concerned. I was like, oh God, like I have to make sure that what we've seen happen in these studies isn't going to happen to her. And she had an amazing experience. And I think we have to start like lifting up some of that too. She had a very quick solution, quick planning, quick scheduling. She had a nurse navigator, and she lives in Virginia. Her work was in Virginia. She had a nurse navigator who advocated for her in ways that are similar to how I would have advocated for her. So I'm like, how do we get more of those? Like, how do we get more people that you're a stranger, but you see my humanity and you see that I'm deserving of the best care possible. And you're not going to sit there and let your colleagues give me anything less than that. To have the advocate in real time who can interrupt what's happening in real time is just critical.
How does the opioid crisis affect healthcare for Black populations?
Oh gosh, these are some deep questions that like it's difficult to answer these like quickly, right? Because there's so much context around these questions. But one of the things, well, I will just say that, and it can go all the way back to kind of the biological and genetic ideas around differences in Black people and how we experience pain, right? So opioids weren't prescribed to many communities of color because the expectation was that they are just prone to, getting hooked, and we're just not going to do that. And so what we saw, especially early on in the opioid crisis, was it was affecting mostly white communities, but that does not mean that it's not also affecting communities of color, right? So I think, what's happened is that the opioid crisis has been treated more like a public health issue, while issues like the crack epidemic, or I'll put that in quotations, was treated like a criminal legal system issue. So we lock people up versus providing people with care. And so those are real important differences to think about, again, when we're talking about healthcare. And so part of the result of when people are in pain, it's like they're not getting treated in the way that they should. They're not being referred to pain specialists. They're not getting the prescriptions that they deserve. And they're having to experience a lot more pain during surgery, or during healing after surgery, I should say, than their white counterparts might experience. So and all of this is around narratives, right? Like narratives that are not based on facts, but that impact decision-making at every step of the way. And our systems, because of the way that they're structured, they don't lend themselves to doing anything about it.
Wow. That's all the questions that I think we have. I have a question though too. What can we do as community organizers to help get people in touch with people that have gone through this training, about, kind of, in a sense, getting rid of the racism and having the racial disparities training? Because I feel like if everyone, why isn't it required for all doctors that practice anywhere to learn about racial disparities?
Well, and you know what, Tony, I would ask that question for any field, right? Because I'm like, why are my baby's teachers not learning about race and racism?
Right.
Because it happens in school systems. Why are healthcare providers, nobody's really required to know anything about the fact that they're producing these outcomes, right? And so then you ask them if they're doing it, and they're like, of course not. I'm a nice person. Like, I mean well. And I'm like, that's not going to get us anywhere. Because if you can't admit that it's possibly happening in your classroom, in your office, then there's literally nothing that people are going to do about it. But I will say that I think it's important that the training is not the end all be all. I say the training is a tool. It is not the answer to racism. And I think a lot of people will go to a training and then that's it. They go to the training, they get a little bit of information, they get motivated, that motivation may last a month, right, before they go back to kind of doing things the way that they've always done. So for me, the answer is really in base building and organizing. And so it's finding your group of people that you feel like you have some type of, ability to learn with and to grow with and to hold each other accountable in ways that that allow you to be a part of a movement, that is marathon work, not sprint work. And, I think for me, a lot of that came from the Health Disparities Collaborative. But before, I started doing this, in my research, I was involved in organizing in Durham, which is where I live, and I'm still connected to those, communities. And so it's about, having that support. Anti-racism work is not an individual level endeavor. It is about organizing communities, organizing in every institution that you find yourself in or that you have some type of connection with, because it shows up everywhere. And you have to stay committed, you have to stay connected, and you have to strategize, that I think that's a really critical thing. So yeah, I mean, we're the collaborative is just, one county over. And so there are a lot of things that I bring into spaces that I'm in from the collaboratives approach and saying, well, why can we think about this? How can we do this? Or how can we factor into this? And I will also just say that community organizing and institutional organizing are very different beasts. They're very different beasts, but having that inside outside collaborative kind of work to push institutions in the directions that they need to go is really critical. So the collaborative couldn't have, or I should say the hospital, there is no way that hospital could have done what they have done if they didn't have the community members knocking on the doors, holding them accountable, making them, holding them to task for what it was that they said they were going to do. Now, the interesting thing is, I always say at the end of the day, institutions are going to institution, right? So the collaborative was created by community organizers. And there was a point in time, and I think we can say this out loud, where, the institution was taking a lot of credit for all the work that the community had done. And so we had to have a meeting, we had to have a moment where we said, this can't happen. Like, you cannot erase the work of community folks in creating the opportunity to even do this in the first place.
Different cultural appropriation.
Yeah, pretty much. Yeah.
There are two more questions came in. Have you seen similar healthcare disparities within the jail and prison systems?
It's everywhere. I'm sorry. I hate to say that, but it's everywhere. I was a part of there was a statewide collaborative that was dealing with pregnancy and incarceration, and they're shackling people. When you talk to people who've been incarcerated, it's interesting because I teach a course about the intersections of public health and criminal legal system. And so I'll have formerly incarcerated folks come and talk. They can all tell you about racism that happens even among the incarcerated. So-and-so is pregnant and she was housed closer to the, where we ate than this other Black person who was pregnant who had to walk like up this big old hill. Or so-and-so was given the benefit of the doubt when they did this, but so-and-so was always penalized for this. So it shows up within jail and prison systems. We see it with COVID, right? Like the lack of protection that people who are incarcerated have had during this pandemic, the way that people have been transported from prison to prison, taking COVID from one place into another, the number of cases that they found among people who are incarcerated. And we see it in care, the longer the sentences have been, people who are incarcerated are having chronic healthcare conditions that need to be taken care of, that need to be, they need to see providers on a regular and consistent basis. They need medication and people need access to contraceptives in jails and prisons. And there have been times where those have been outlawed, right? So it absolutely shows up. And if we think about the fact that Black and brown people are disproportionately represented in our prison and jail systems, then it just is layer on layer on layer, right? Like, so we can't ever not just look at it, it's kind of like as a single thing issue. It's always the complexity of it all. So sometimes when people are like, what can I do? One of my first answers is just think a little bit more about like how intricate this is, because sometimes people want to act really quickly. And sometimes those actions actually make things worse. And I know that's nobody's intent, but that's what can happen when we don't diagnose problems correctly.
And is critical race theory being discredited in health systems like it is in education systems?
Probably, I'm sure. But I really, for me, I really try not to spend too much energy dealing with that. That is the whole critical race theory in education. First of all, I thought it was really funny. I read the legislation that the Republicans have put forth around critical race theory. And so much of it was about like individuals are not this, individuals are not that. I'm like, have you read critical race theory? Like it's about systems, So it was just even the disconnect between like the language that's being used. But I have not heard in our healthcare system as much angst around it as I have in our education system. At the same time, there was all this controversy a few months ago when there was a podcast and somebody from the American Medical Association said that racism is not an issue in health. So, so we still have a lot of work to do. They didn't name critical race theory specifically, but that blew up. That blew up in a lot of different ways.
Can anyone take the Undoing training?
Yeah, so the phase 1 racial equity training that's offered by Racial Equity Institute, it's organized by community organizations. So like in Alamance, it's AREA, Alamance Racial Equity Alliance, Durham, Organizing Against Racism Durham, Greensboro, it's GARA, the Guilford Anti-Racism Alliance. So you can go to REI's webpage and see what are being offered. And all of those groups do offer scholarships too for people who need some financial assistance to be able to attend. I highly encourage, if you want to go and you feel like it's cost prohibitive, reach out to the organizers and have some conversations. I also encourage you to reach out to, if you have an employer, I would encourage you to reach out to your employer and see if they will pay the costs for it. A lot of organizations, especially in this moment, have funds set aside for what they like to call DEI, diversity, equity, inclusion. And so sometimes there's resources to be able to attend these trainings that you have access to. And I feel like actually there's a groundwater training in Alamance. I see Matinde's here. Maybe she can put that in the chat or give the information somewhere. But I believe it's on Thursday, right? Is there one Thursday?
Yeah, so the one on Thursday was unfortunately canceled due to poor attendance.
Okay.
But we do have one July 10th that is definitely going to be happening. And we've got the phase 1, which is the 2-day training, June 21st and 22nd. But I'll drop that information in the chat down below for people to read more about it.
Awesome.
Thank you.
So I think that concludes the questions. I don't see any others coming up in the chat, but Tony is checking behind me to make sure I didn't miss any of them.
Okay.
I want to thank Dr. Stephanie Baker for the millionth time because every time I call upon her, she shows up, and I think that you will all agree with me that she does in fact show out, and she makes you think and learn and reevaluate. And I don't know about the rest of you, but I really am ready to process and see what we can do to affect change in Alamance County. So thank you so much, Dr. Baker. My phone and my Facebook comments are blowing up with people saying, she's so smart. I never thought about that. So I just want you to know you have a whole fan club now, and it's great. I love it. I want to thank Mtinde for her amazing information. If you check our chat, you will see some information about doulas in Alamance County. You'll also see information about the Racial Equity Institute trainings. All of that came from Mtinde. So I'm so thrilled that she was able to be here and able to offer that information. I want to thank everybody who was gracious enough to assist in coordinating this event. It was a very much so a group effort. There were a lot of heads at the table, and I think that this was a necessary conversation, and just the insight that Dr. Baker gave proved why it was so necessary. I want to thank everybody on Facebook and everybody on Zoom who showed up. Thank you for your questions. If you scroll up, you will see 2 different sets of links. Those are the links that Dr. Baker has referenced throughout her conversation. So some of you might have missed the first round of links. So I posted them again. They're also shared on Facebook. Several people have shared the Facebook video. So if you check the comments, you should see all the links for things that have been referenced. Dr. Baker has said that you're able to follow the Her Lab, which was referenced earlier. Instagram and Facebook, it's at her_lab_Elon. And they are doing some wonderful things over at Elon University, making me very proud to be a Phoenix. So like there is only one true way to close this out, and that is to close this out with the words of Dr. Baker. So during the course of this presentation, she said, "You see my humanity and you see that I am deserving of the best care possible." So to everybody who has tuned in, you are human. Race is a whole other thing. You are human and you are deserving of the best possible care. And if you don't feel that you have received that, then there are channels in which you can work towards improving your healthcare, but also improving the healthcare of others in the Alamance County community. So thank you all for participating tonight. There are future events forthcoming, and we will create Facebook events and provide Zoom links for those events closer to those dates. Have a great night.